All right, thank you again for asking me to give this lecture. I'm probably one of the last few endocrinologists who actually give radioactive iodine myself. So I make the decisions and have looked at the guidelines, and what I hope to do is to go through the 400 pages of the ATA guidelines and condense it down to clinical practice. I actually already know that this is not going to be totally accepted by this audience, because listening to how you responded in the past to other questions, but let me put forward my thoughts. So this is going to talk about the initial staging of differentiated thyroid cancer and how we decide on whether a patient should have radioactive iodine therapy or not. I have no disclosures. And in the past, treatment of thyroid cancer was very easy. In fact, that's probably why I started in the area of thyroid cancer, because everyone had surgery, everyone got radioactive iodine, and we gave everyone suppressive doses of thyroid hormone. So in 2016, all three of these areas are now being questioned, and that's probably good, because we're going to reduce the complications of our patients. So I was actually sat on the 2009 guidelines for the ATA. I was not part of the 2016 guidelines, or 2015, published in 2016. So I will be able to give you sort of an outsider's view of the new guidelines. So what is important and what is continued from the 2009 to 2016 ATA guidelines is that we're moving towards a more individualized therapy. There is no more cookie cutter. There is no more one treatment is for every patient. And in fact, what the big move is for little or low dose radioactive iodine for most patients with thyroid cancer. So the paradigm, as I said before, everyone had surgery, everyone had radioactive iodine, everyone had thyroid hormone suppression. And now what we recommend is doing a risk-adapted paradigm. That is, look at the patient's risks for death and risks for recurrence to determine if they need radioactive iodine. And why the change? In part, the way we managed patients were based on macro disease, because we didn't have fine ultrasound. We didn't do cross-sectional imaging on every patient. So a lot of our decisions to do therapy were really based on patients with a big volume of disease. We're shifting down to patients with low volume disease, and we cannot treat them the same way as patients who had a large burden. So what we're hoping to do now is talk about the risks, the pattern, looking at the patient's presentation, figuring out what their risk of recurrence and what their risk of death is. So as always, I like to start with a case. 22-year-old woman. She had a total thyroidectomy in her right neck section because she had obvious lateral neck metastatic disease. She had a 2.5 centimeter multifocal, well-differentiated papillary carcinoma, had gross extrathyroidal extension, and positive lymphovascular invasion. She had 20 of 32 positive lymph nodes, both in both sides of lateral 6 and also on the right lateral neck. The largest node was 3.2 centimeters. Her post-op thyroglobulin, as you realize, is quite high at 25 with a normal TSH. And the question is she high risk or is she low risk? And the answer is she is both. So let's see if we can figure this out. So the first way you have to look at this, and we've heard this already from other speakers, is that you need to stage your patient. So when we look at the guideline, at the AJCC staging, it looks really complicated. It's very easy. So if you're less than 45, stage 1 is everything except distant disease. If you have distant disease, that only makes you stage 2. Over 45, the first 3 stages just depends on size. Less than 2 centimeters is stage 1, 2 to 4 centimeters is stage 2, greater than 4 centimeter or microscopic extrathyroidal invasion makes you a stage 3. Stage 4A is going to be lateral neck nodes or gross invasion outside the thyroid. Stage 4B is going to be encasement of the carotid artery or mediastinal vessels, or invasion posterior into the prevertebral fascia. Stage 4C is distant disease. It actually is not that hard to actually think about this because it's really a progression of disease. So AJCC staging is important because it allows us to talk with each other and we can figure out what the extent of disease of the patient is. This is what we've seen before, and I actually sort of object to the concept that no one dies of thyroid cancer, and that's not really true. Now, 75% of patients are stage 1 and 2, and the risk of death is quite low. But the other 25 patients are stage 3 and stage 4 disease with a significant risk of death over a period of 10, 14, 20 years. Now, if you look at the stages, you can see that the staging does predict the risk of death. And this is actually something from Mike Tuttle, that if you look at the AJCC staging in his group of patients, that the risk of death did go up as the AJCC stage rose. It is also true that the risk of death was actually quite low in his group of patients for AJC 1 through 3. But if you then look at that population of patients and say, what is the risk that that patient is going to get a recurrence? Does not correlate with AJC staging. So stage 1 disease had 34% of the patients had recurrence, stage 2 was 51%, stage 3 was 37%, stage 4 is 62%. So AJCC staging is very good to predict the risk of death, will not help you determine the risk of recurrence. So what do? So this is when the ATA in 2009, when I was on the guidelines committee, decided that we needed another staging system. So the AJCC staging works with AIMS and AGES and MESAS, and they all predict risk of death. They don't predict risk of recurrence. So what we decided is that we would actually create a guideline where we said there were 3 risk categories of patients. And these risks that are in these categories are not necessarily part of AJCC staging, and that's why it works. So I'm going to have both the 2009 guidelines, and I've also highlighted in white the additional information from the 2015 guidelines. So the low risk is the classical papillary carcinoma. No nodes, no invasion, sort of no nothing. The one thing is that if you give radioactive iodine, there's uptake only in the bed. The one addition from the 2015 guidelines is that if you have low risk is also considered less than 5 lymph nodes, less than 0.2 centimeters. So what this does is one of the arguments about doing central neck prophylactic dissections is that you find all these micro metastatic nodes, which upgrades a patient from 1 or 2 to 3, which does not reflect the risk of death. So what this staging does, it says that if you have microscopic nodes, they do not increase your risk of recurrence, don't increase your risk of death. Intermediate risk is the microscopic extrathyroidal extension, cervical lymph node mets, aggressive histology like tall cell, and vascular invasion. So lymphovascular invasion is not part of AJC staging. It actually is a really important factor for determining recurrence. And then again, if you have more than 5 lymph nodes, especially if they're in the clinically evident range, sort of 6 millimeters to 3 centimeters, that's in the intermediate risk. The high risk is macroscopic gross extrathyroidal extension. It's patients who have incomplete tumor resection because it's invasive. It's patients with distant disease. And what's new from the 2015 guidelines is that if you have those big lymph nodes, bigger than 3 centimeters, that actually places you in a high-risk category. Again, I think we're going to hear actually next, or in the next couple of talks, about post-operative thyroglobulins. And when it's appropriately high, it actually is also a high-risk category. Okay, so this is actually from Dr. Weisman, who's in the audience here, and is a very important study here from Brazil. And what he did is he looked at the ATA staging in 2009 and applied it to his population, which if you look at the red, the ATA staging again predicted the risk of death, 0, 1, and 17%. I'm saying AJCC. The ATA risk actually very accurately categorized patients for the risk of recurrence. So as the risk went up from low, intermediate, and high, the risk of recurrence went up considerably. So let's go back to look at this. So if we look at low-risk patients, we think their risk of recurrence is somewhere to 10 to 15%. If we look at the intermediate risk patients on the ATA guidelines risk assessment, it's 25 to 45%, and high risk is very high, somewhere 70 to 90%. We'll go back to this patient that we just saw. She's 22 years old, so she has AJC stage 1 disease. She has a low risk of death. Her MESA score is low, but her ATA risk is very high because she has a 3-centimeter node. Her thyroid globulin is greater than 25, and she also had lateral neck nodes. So when we look at this, her risk of recurrence is going to be in the 80 to 90% range. So, and that's the patient who, even though she's 22, is unlikely to die of the disease, needs to have radioactive iodine therapy. So again, we're going to go, our goal of therapy for radioactive iodine is we're going to base it based on AJC staging and risk of recurrence with the ATA risk assessment. The goal is to really reduce the morbidity of radioactive iodine. There are many long-term complications which the audience already knows about, including salivary dysfunction, loss of teeth, dry mouth, that we want to avoid. And the other problem is that with our improving thyroglobulin assays, we're making people have persistent disease. So many of our patients with persistent disease is biochemical persistence, and a lot of those patients do not need additional therapy. Okay, so I want to go through the guidelines. It's not as complicated as you think. And in fact, I actually tell my fellows they need to copy these and have them at your desk because no one expects you to remember them. So the first thing I want to look at is we have the description of the tumor. We have whether radioactive iodine is recommended. And then what's really important here is this is disease-specific survival. So does radioactive iodine improve with the risk of death? And the second column is, does radioactive iodine reduce the risk of recurrence? So in stage 1, this less than 1 centimeter, whether it's multifocal or not, you can have 10 foci in the thyroid, that's 2.1 millimeters. There is no evidence that it reduces death, reduces recurrence, and it is not recommended. So we don't give radioactive iodine to less than 1 centimeter tumors. Now, this is much more controversial. I have to say that even I sometimes have a problem with this number. So if the tumor size is between 1 and 4 centimeters, almost all of us gave radioactive iodine 5 years ago. The ATA guidelines is basically saying it should not be routine. There is no evidence it improves their already good risk of not dying of the disease. There's conflicting observational studies. Again, Electron said we don't have double-blinded case studies to try to prove that radioactive iodine will work in this group. But you might consider this, so it's not going to be routine, but in those patients who have aggressive histology or that lymphovascular invasion, which is not on the AJC staging, that's the group of patients who you might give radioactive iodine to. What about the greater than 4 centimeters? I struggle with this one a lot myself. I have to say that I sort of use my own judgment, and I tend to give patients ablation. It may not be a high-dose ablation, but I usually do ablate them. So the evidence that it reduces death is conflicting. The evidence that it reduces recurrence is conflicting. And basically what you're going to do is you can consider other things. You're going to look at the age. The older a patient is, the higher the risk of recurrence is going to be. And you might actually consider, based on those sorts of factors, whether to give radioactive iodine. But what you're noticing here is no tumor less than 4 centimeters is routinely given radioactive iodine anymore. You really have to think about this. This is totally different than what we did even 3 or 4 years ago, and it's a new concept that you really need to grasp because it will reduce the morbidity to our patients. Okay, what about the patients with extrathyroidal extension, the microscopic form? Again, no evidence of reduction of death. There is conflicting evidence about reduction of recurrence. And again, this is now considered generally favored. So even though there is no evidence that it reduces death and recurrence, in general, the expert opinion is that with extrathyroidal extension, there is an increased risk that makes them an intermediate risk for recurrence, that they should receive radioactive iodine ablation. Now, what about lymph nodes? For central lymph nodes, in general, again, everything is conflicting in terms of risk of death and risk of recurrence, but it also is generally considered favorable, and they recommended that certainly patients who are older, patients with larger lymph nodes should receive radioactive iodine ablation. It gets easier as we get more advanced. And lateral neck nodes, again, considered and general favored, but again, there's no data. There's no objective data saying that we're improving risk of death or recurrence, and this is really clinical judgment. When you finally get to the highest risk category, that's gross extrathyroidal extension, distant metastases, there is objective scientific data saying that there is a reduction in death and a reduction in recurrence if you treat that patient population with radioactive iodine. Okay, so let's go to the test case, and we're going to do it as a audience participation. So a 46-year-old female, she has a 3.4 centimeter thyroid nodule. The biopsy is consistent with papillary thyroid carcinoma, and she undergoes a total thyroidectomy with a 3.1 centimeter papillary carcinoma, follicular variant, totally encapsulated, no extrathyroidal extension, no lymphovascular invasion, no nodes, BRAF negative. Her pre-op ultrasound was totally negative for any adenopathy. So the question is, she's an AJCC stage 2, she's an ATA risk low. So is there evidence, or should we treat her with radioactive iodine ablation? So I want hands for yes. Oh, no one's going to vote. I want hands for no. Okay, a few more. See, you listen to me. The answer is no, right. So if we go back and look at the actual tumor of greater than 1.4 centimeters, and then it is not routine, and you would consider it for only aggressive histology. And in fact, if you listen to our pathology expert that was just up here, we should even consider that the encapsulated form of the follicular variant of papillary should not maybe even be called a cancer. So she definitely should not receive radioactive iodine. Okay, I've also heard a couple of times during this meeting, well, maybe we need radioactive iodine or a total thyroidectomy in order to use the thyroglobulin as a tumor marker. So there is a retrospective study of patients who had a total thyroidectomy or a near total thyroidectomy, so not even a total. It was a multi-centered trial in Italy. It was a median 5-year follow-up, and there were 290 patients they looked at, and they compared it to 490 patients who did receive radioactive iodine with the same staging. And then they looked at the temporal trend of the thyroglobulin. And what they found is if you look over a period of 7 years at the line, which is the actual serum thyroglobulin, you can see that even without radioactive iodine, interestingly, the thyroglobulin has fallen. This is a trend that actually Leslie DeGroot described in the 70s. I remember reading a paper from him saying that thyroglobulins fall without further treatment, and this is a current study that actually totally confirms this. And what they found was by 80% of the patients after 5 years ended up with a stimulated thyroglobulin less than 0.2. So what this says is that you don't have to have radioactive iodine ablation to follow a thyroglobulin. It's a caveat there. You need to have great surgeons, and it sounds like in Brazil you have lots of great surgeons, but that actually requires a good surgeon in order to achieve this, but you don't need radioactive iodine in every patient to follow a thyroglobulin. So in summary, the 2015 ATA guidelines emphasize individualized care of the patient with differentiated thyroid cancer. The patients need to be staged, not just for AJCC for the risk of death, but the ATA risk assessment for the risk of recurrence. And when you look at those two risks, you then can make a decision whether to treat with radioactive iodine. Again, most patients with low-risk disease will not need radioactive iodine based on these recommendations. Thank you very much.